Well, good evening, everybody, or good afternoon, depending on what part of the country you're in. I'm John Hovannessian, and welcome to the Ophthalmic Clinical Education Summit, sponsored by Zeiss. I'm really happy to be involved in this series of talks, and I hope you've taken advantage of some of the other sessions that are happening in a variety of specialty areas, including retina and anterior segment. And this begins our surgical series. We have seminars where we're going to talk about best practices. And you know what I really like about this series of webinars that we're doing is this is physicians talking to physicians. We're not giving you advertising shtick. We're not giving you information that you don't need. We're telling you live what we do. And hopefully that makes it valuable to you and your practice. So I welcome you to participate in all of these. And I'm particularly excited about the faculty that we have involved today. So I have the pleasure of introducing and being here with a faculty that is some of the brightest minds in anterior segment work. So starting will be Sumitra Khandelwal, who's an associate professor at Baylor in Texas, and joining us right after her, Liz Yu from Virginia Eye Consultants in Norfolk, Virginia. And Virginia Beach is going to share some insights. We're going to talk about real world issues with choosing lenses, formulas, technologies to achieve our best results in patients. And probably the best part of this is going to be some case studies that we do toward the end. So I invite you to listen first to Sumitra, and then I'll introduce Liz shortly after. So Sumitra, you're there, and we've got your slides, and take it away.
So I'm going to talk a little bit about how to pick that perfect lens for each patient. Now, it's a little bit less of a nomogram and more of an art, really understanding the patient's goals and knowing the different options available, but we'll at least discuss some steps to success to guide the decisions. So the first step is really understanding what the patient wants, their goals, and you can do that with the questionnaire. So much thanks to Steve Dell and Liz Yu for their different options for lifestyle questionnaires. You can utilize this one that really discusses activities. You can have the patient check off the ones that they do now and underline the ones they really want to do without glasses. And this can be really nice because patients oftentimes don't know what distance versus intermediate versus near is. But if you're allowing them to discuss this more on a activities basis, they can really understand what the different options are. You also can keep it simple and just discuss about distance versus mid-range. But the key is whether or not they're okay with some of the side effects with these lenses, like halos, rings, and starbursts, which you should always counsel patients when they're interested in presbyopia correction. And then if they have the option and insurance didn't cover it, would they be willing to pay out of pocket for it? And so those are two key questions to ask patients, and you may be able to garner that information prior to even stepping foot in the room, which is nice. You also want to perform a proper preoperative examination. This includes, in my clinic, a topography, a retina OCT, a very careful evaluation of the ocular surface, and quality biometry. The slit lamp exam tells you so much, but oftentimes a placido image can give you a lot of information, but more importantly, it guides my technicians to what to do with this cataract evaluation. So they see a patient who has a placido image like this, they stop the exam, and they come and grab me before they can administer any drops, so I can take a look at why these Myers are so irregular on their placido image. Similarly, with the OCT, I like to know what their OCT looks like before I go into the room. My dilated exam is adequate, but it's certainly going to miss small pathology that the macular OCT can find for me. And I want to discuss with the patient if they're not a good candidate for some sort of presbyopia correction based on the retina OCT prior to my even examination of them. Similarly with the ocular surface, we know there's a lot of work being done on ocular surface, and we know that the changes to the ocular surface after cataract surgery can worsen preoperative dry eye. So I always look for meibomian gland disease, any evidence of staining, decreased tear breakup time as examples, and talk to the patient about it prior to surgery so if they have any road bumps afterwards, we can go back to the fact that this was a preoperative diagnosis and we can take measures to pre-treat them to avoid postoperative dry eye. And quality biometry, as we'll talk later on, is very important. Being able to use the correct formulas, being able to optimize the refractive target, and make sure that you're able to, target a certain focal point and really get there using the tools that you have. It's very key to reach the refractive target in these presbyopia correcting lens options. And you want to be familiar with these options, and there are a lot of options. So you've got the monofocals and the toric monofocals. You have accommodative lenses and then multifocal lenses. But under that category of multifocals, you've got extended depth of focus, you've got low ad multifocals, you have higher ad multifocals, you have toric options for all of them, and now you have trifocal and quadrifocal options. So it certainly can get a little bit overwhelming as a surgeon. Which lens do I offer this patient? And you can't offer all these options to the patient because they will get triply confused. And so I think it's really important that you narrow it down and decide which one you're going to offer these patients if they are in fact interested in presbyopia correction. So we'll talk about some of the pros and cons of each. So we have monovision, and monovision is very successful in a subgroup of patients. Oftentimes they'll come in with a history of monovision, and you can see in the black line in this defocus curve, they have that good quality vision at intermediate and near compared to the control group. And they have a high quality of satisfaction in the studies, although I think sometimes this can be a little bit self-selected. Oftentimes we're doing monovision in patients who've already proven that they've done well with monovision in contacts. But there are some downsides. There's loss of stereo acuity, especially if you're doing true monovision as opposed to a mini monovision. And these patients may have spectacle dependence for certain activities such as night driving. And to me, a successful monovision history, there's a little bit of gray zone with that too. Take the 65-year-old who presents with desire for distance and near, who's had quote-unquote successful monovision. I like to ask them how long ago was the monovision and why did they stop? So this patient did great with monovision up till a year ago, but they were tired of their contact lenses and they're okay with spectacle dependence for certain activities. Great monovision candidate, although maybe more of an intermediate aim for that non-dominant eye so they don't lose all their stereopsis. But this is a different type of patient who had a history of monovision, but that was more than 10 years ago, and they felt the vision wasn't as good, and so they stopped doing monovision. 55-year-old phakic monovision is very different than a 65-year-old pseudophakic. And so for this patient, when you really get down to it, they want a true spectacle independence for distance vision and for intermediate. So I went with a low ad multifocal, and this patient did very, very well and rarely uses over-the-counter readers because their near needs are not that much. So a history of successful monovision is key. Doing the near eye first is always excellent if you can, because you nail that emmetropia for the second eye at distance, and then counseling the need for glasses. Now we have high ad options for multifocal lenses. You can see here in the J&J platforms, you've got the ZMBU, which is in purple, but you see that big drop off at the minus 1.5 defocus. Compare that to the green and the blue of the lower ads. In addition, you see that in other platforms as well, the orange without that sharp decrease at the minus 1.5 compared to the orange of the 4.0 has a big sharp decrease at minus 1.5 compared to the purple of the 3.0. And so you also have a little bit more photopsias with the higher ad multifocal. So they're really not as popular as they were when they were the only option. With the lower ad multifocals and the EDOFs, you get less diffractive rings, so less photopsia in contrast. And there are toric models available as well. And the key is the intermediate target that they really allow for. But there is a little bit of cons too. There's a lack of repeatable near vision, and you still get some glare and halo with these lenses. You have also options with blending, doing a blend between two different types of lower ad multifocals, or for example, with the J&J platforms, you can even do something where you do the dominant eye with the Symphony, and then if they want more near vision, go with a low ad multifocal in the other eye. And lastly, for those eyes that don't have issues with the cornea or the retina, and you're not as concerned with any glare or halos, the quadrifocal is an excellent, excellent option. So we have the Alcon Panoptics available, and this can give you high distance and intermediate vision and near vision as well, and really been amazing for our patients because it allows all three focal points. But you do have to be concerned about glare and halos and contrast issues, and that's something that we counsel all of our patients about. So if this is still a lot of options, I kind of like to break it down. So desire spectacle independence. If they don't, then you can go straight with the monofocal option. If it's something that they desire spectacle independence, but there's something abnormal about the eye, let's say they have retina pathology or they have advanced glaucoma, well, you talk about some of the options, but you let them know they're just not good candidates for that and that you would advise them to go with a monofocal option. If, however, their eye is relatively normal, perhaps they have mild pathology or mild issues for why you're concerned about contrast tolerance, say they've had prior refractive surgery, maybe they have mild to moderate dry eye, perhaps they have issues that are very mild as far as the retina goes, you can go similarly with the monofocal options for them if they don't want to risk that. But if they're highly, highly motivated for spectacle independence, you also have the option for low ad or EDOF lenses. And I like to go with the first eye and the dominant eye. And if they're satisfied with the near or intermediate in that first eye, then match it up, do the same lens in the other eye. But if they want a little more near in that first eye, then you can kind of do these mixing and matching between the low ads and the intermediate ads, as well as the EDOF and the low ad multifocals. And if they have that pristine eye, perfect cornea, perfect retina, the quadrifocal option can be an excellent one and really cuts down the chair time because you're not really having to give up distance, intermediate, or near. You're able to get all three with the quadrifocal lens option. And really, it's this middle ground here, this gray zone. That's where cases and examples really become best. And we'll go over a few of these options here and what we did for each of those patients. Lastly, there can be a whole talk about ways to troubleshoot, but I think the real key is when looking at large arrays of patients that were dissatisfied over multifocals, it came down to not being able to target the refractive error, the ametropia, unrecognized dry eye, and PCO as well. And so these are reasons why patients weren't as happy. And most patients in this study, for example, did not need an IOL exchange. They really just needed their refractive error corrected as well as dry eye management and a possible YAG. So there's a variety of presbyopia correcting options for cataract surgery. It's not really which lens is best, but what's best for the patient in your chair. You want to determine how this fits into your practice and how to troubleshoot any issues post-operatively. Thank you.
Sumitra, outstanding. I love your family pictures too. That's terrific. That was a great decision tree. I like your logic a lot, and we're going to talk a little bit more about some of the formulas now and get a little bit more nitty-gritty on power selection. And then I'm going to talk for just a few minutes after Liz Yu about an approach we have to patient profiling to decide what's the best, to guide us in the lens selection. So Liz, tell us about pearls for IOL selection and how to get those best patient outcomes. Liz Yu.
Hi, my name is Elizabeth Yu, and today we'll be talking about pearls on IOL selection and lens calculation in order to optimize our patient outcomes. I do work with different companies that are relevant to cataract surgery. When we look at IOL calculations and those axial length considerations, truly, when we look at the normal eye, which is about 72% of our patients, all formulas between modern as well as other formulas that do not take into account the effective lens position, you can see that they pretty much work quite well. It's really those axial lengths that are either quite long or quite short, where we can have more of those surprise outcomes. And of course, we need to consider their prior surgical history, such as LASIK. When we look at longer eyes, for example, we can break it up to either long eyes or very long eyes. 24.5 to 26 millimeters is about 15% in prevalence, and those with very long eyes beyond 26 millimeters is about 7%. And the performance of these different formulas actually can depend on that axial length and how long the eye actually is. Barrett Universal 2, Hill RBF, even Holiday 2 have all been considered here. When we think about, there is also an optimized axial length formula where you can use your Holiday 1, Haggis, SRKT, or Hoffer Q, those which perform very well in your average axial length, and it can be optimized using the formulas as you can see here in order to then plug it in and change that and still use that formula of choice. Now, short eyes, less than 22 millimeters, is approximately 8% of the actual population. And when you look at the various different the formulas that are available, that demonstrates that when looking at the meta-analysis, the overall evidence demonstrates that maybe Hygus performs and outperforms the other various formulas. So with newer generation formulas, this is where you can find them. Okay, so when we look at the Barrett Universal 2, it is absolutely included with the IOL Master 700, including the entire Barrett suite, which also allows you to have the True K for your post-LASIK, as well as your toric calculator. It's also housed in the LensStar. The Hill RBF formula you can find on this calculator, as well as on the LensStar. The toric IOL formulas, as you can see here, as well as looking at the Abulafia-Koch regression formula, which allows you to, again, use your favorite formula of choice. And then your post-LASIK eyes and your Barrett True K can be found on this specific website, or in the Barrett suite of the IOL Master 700. It can also be found on the ASCRS calculator. Now, fourth generation and modern formulas. When you compare them all, it looks like the Barrett Universal 2 actually performs very well at all axial lengths. When you are looking at the average length of 22 millimeters and above, Barrett Universal 2 more accurate than other modern formulas. When you're looking at really short eyes, maybe there's no really statistically significant differences in the median absolute errors. In very long eyes, so over that 26 millimeters, only the Barrett Universal 2. So what it means is the Barrett Universal 2 actually outperforms the optimized axial lengths. And it did perform well for just your long as well as your very long eyes. The Barrett Universal 2 can be found at the APACRS website, but it is automatically found as well in the IOL Master 700. Now, when we look at the idea of radial basis functions, radial basis function algorithms are used very widely. So it is part of EKG formulation, facial recognition formulation, and what it is somewhat to simplify a math formula in order to take some specific inputs in order to get an output, and then using some level of deep brain function and artificial intelligence, it refines itself in order to get the best outcome possible. So the Warren Hill RBF formula is one that is utilizing radial basis functions, which is independent of effective lens position or vergence, and the actual four variables, as you can see, are listed. The RBF calculator can be found on the Hill RBF website, but this is the actual web address for it, which is rbfcalculator.com. And the Hill RBF formula, as presented at the 2016 ASCRS Symposium, demonstrated that within the predictive refractive error of a half diopter target, most patients with an axial length of over 25 millimeters, of 98.4% of patients, they were within that prediction error of half diopter. Over 92% of eyes with average axial lengths, and it actually performed quite well in axial hyperopes as well. So when you actually go to Dr. Hill's website, demonstrates that for very long eyes, it actually preferentially uses the Barrett Universal 2 as well as the Hill RBF in order to look at the calculations, and it takes into consideration the Holiday 1 optimized axial length. Now, when we are looking at post-refractive surgical eyes, post-LASIK, PRK, or RK, the ASCRS calculator has all of these various formulas, as you can see here on the left, listed. The reason that I still go to this calculator is because when it does give me the information, I like to see the range. That range allows me to get a sense of how good the overall bed and the patient's aberrations yield in outcomes. Now, looking at the Barrett TrueK formula, it actually outperforms or is equal to other formulas that are on the ASCRS post-refractive calculator. And when you're looking at multifocal lens implants in prior myopic LASIK or PRK eyes, the IOL formulas when you have all the historical data, Masket, Modified Masket, and Barrett TrueK perform equally well. But when you have no previous data, the Barrett TrueK performs the best with the lowest amount of mean absolute error. Now, does total keratometry, which is found on the IOL Master 700, help? It looks like when you're comparing formulas with and without total keratometry or the TK values, it can be helpful. So when you're looking at the various formulas, it does seem that the Barrett TrueK and the Hygus TK produce significantly lower mean absolute errors than the Hygus formula. This is for your myopic LASIK group. Your hyperopic LASIK PRK group, there was no statistical difference seen between the formulas, but the Barrett TrueK does seem to perform at least equally well. And lastly, looking at SAA values, it is important to understand that if you are operating temporally and your wounds are less than 2.4 millimeters, based on centroid, so average vector analysis, it turns out that the SAA value is about 0.11 diopters of flattening. So even if you are not going to calculate your own very specific surgically induced astigmatism, the average will be about a 0.11 diopter flattening effect if you are a temporal surgeon. So when we're looking at refractive astigmatism, it is more than what's in the anterior cornea, and we well recognize that the posterior corneal astigmatism must be accounted for. There are various normograms and online calculators that account for posterior corneal astigmatism, including the Barrett toric calculator, which can be found on the ASCRS website. It is also housed in the Barrett suite of the IOL Master 700. It is part of the updated online Alcon toric calculator. And then when you're looking at the specific AMO or J&J online toric calculator, it is accounting for the posterior cornea, but it is through proprietary in-house analysis, not accounting for not using the Barrett toric nomogram or algorithm. Now, I recently published a small study that demonstrated that if you are looking at residual refractive astigmatism, taking into account the posterior corneal astigmatism with the Barrett toric calculator, 98% of eyes, 50 eyes together, have a residual refractive astigmatism error of less than half diopter. But what's very important is to recognize is that if you are really trying to tighten your outcomes, accounting for posterior corneal astigmatism with the Barrett toric algorithm, 80% of eyes have less than a quarter diopter of residual refractive astigmatism. And when you actually back calculate, going to one that only accounts for anterior corneal astigmatism, as you can see here, in the orange, that only 50% of the time would you actually be within a half diopter of residual refractive astigmatism. So absolutely account for that posterior corneal astigmatism. And the Barrett toric calculator outperforms other nomograms, as you can see in the table on the right over here. So we also know that effective lens position and IOL tilt can affect astigmatism, especially in shorter eyes. But the Barrett toric algorithm, as well as intraoperative aberrometry, will account for posterior corneal astigmatism as well as effective lens position. But the Barrett toric algorithm, based on personal correspondence speaking with Graham Barrett, for it to show that it is as accurate as it was based on other studies, as well as the prospective study results that I showed you, it has to account for IOL tilt on the toric power itself. One other program I did want to show you, in order to really optimize ourselves, not only do we need the best IOL formulas, which a lot of the Barrett, that's my go-to, Barrett Universal, Barrett TrueK, Barrett toric, it is also the efficiency of the process. And this is where Veracity has really helped me, because it automates the process. It actually takes the information from my LensStar, from the IOL master, from various different topographies, uploads it automatically into this software, and then I am allowed to set defaults, including my actual formula of choice, as well as looking at the different IOLs that I want specifically for this patient without any transcription errors. And as you can see here, I can toggle through which lenses, as well as, if I were to look at the various values of keratometry, and if there's any outliers, what I may or may not pick, it allows me to even use the Barrett integrated Ks, which is looking at the K values amongst multiple different devices. And then ultimately what lenses, including backup lenses, that I would choose, as well as other considerations about this patient, including weak zonules or port dilation. And then that I can approve a plan and absolutely even review the different images that the patient has specific to them. Now this is being uploaded. This includes my atlas, so I can look at the axial images. So I don't have to toggle between a slower data of information, which is just uploaded pictures of these different diagnostics within my actual EMR and EHR system, but it automatically is populated so I can toggle between the different documents. And then intraoperatively, as you can see here, I can create an actual default op note and also adjust it accordingly if anything changes. And the major power is that I can use different parameters post-operatively to within seconds also analyze my own results and to see with each specific lens or each specific formula, how I can actually further optimize myself by either maybe adjusting surgeon's factor, but the power is, again, going to be in this post-operative analysis as well, because I can within seconds now use my post-operative data and look at it in multiple ways. So in conclusion, modern IOL formulas provide superior lens calculations. As we could see, the Universal 2 works well across all axial lengths. For myself, if I have any surprise outcome after the first eye, I always review the data, maybe repeat imaging, but then I review the various IOL formulas and I will adjust for in the second eye. And this is more commonly going to be seen in the extreme axial lengths, the short eyes, the really long eyes. The Barrett toric IOL formula, so important in that it is the most accurate way to account for refractive astigmatism. It accounts for anterior and posterior corneal astigmatism, effective lens position, and IOL tilt. And for my post-refractive eyes, I do use the ASCRS post-refractive calculator, but I always go to my Barrett TrueK. Thank you very much. Hi, my name is Elizabeth Hugh. And
hey, those were two fantastic talks. Thank you, Liz. Boy, that was just packed full of information, and we're gonna get into a little more discussion with the cases that we have after this next talk. And so, thank you for that, Liz. I want to also kind of just put in a word about Veracity Surgical, which you spoke about, and you showed the screenshot recordings of. This is a tool that I think my biggest takeaway as a surgeon when I started using it, and it was almost 2 years ago, is, wow, why didn't somebody invent this 10 years ago? It's the only system of its kind to help surgeons to plan surgery with data from multiple machines. So one of its most useful features, and there are a lot of useful features, is the taking data, structured data from topographers, from your biometer, regardless of which company makes that instrument, and bringing it in. So there's no hand transferring of data from one place to another, which is prone toward errors. And it saves tremendous time, more than 50% of time in choosing lenses, and has really all the formulas you could want to use, including Barrett TrueK and Barrett Universal 2 built in. Just today in the OR, I used it in the OR when I had a case where I wanted to look at the topography. And with one click, I could have topography for this eye right in front of me. So terrifically useful software. Thanks for mentioning it, Liz. So let's move next to measuring not the eye, but the brain, or at least what's on the mind of the patient, to help us understand how to profile. And so let's launch into my talk.
Next, we'd like to talk about a really important element of getting the right lens in the right patient. Just as calculations are critical, so is patient profiling, we're learning. And let's unpack a little bit what that means. First, I work with a number of different companies, including Zeiss, as a consultant. Today, we have a lot of different choices for our patients, including monofocal toric lenses that come from 3 different companies and several different designs that just keep getting better every year. And presbyopia correcting lenses that are also exciting, from those that are extended depth of focus to those that are multifocal, bifocal, multifocal, and then those that are trifocal. Just here in the U.S., we have impressive options, but we sometimes stumble and fall, and hopefully not as badly as she did, when we don't have the right rules in place to follow. So for biometrics, which is the measurement of the eye, we know certain rules follow, like higher order aberration should be less than 0.6 microns. Chord mu should be less than maybe 0.6 millimeters in order to have optimal optics, especially for a multifocal. Visual potential needs to be right. We need to improve the ocular surface and beware of other conditions that limit vision. Those rules we know pretty well, but psychometrics is an area we don't pay as much attention to, and this is really the science of measuring what is not between the patient's eyelids, but what's between their ears, what's going on in their mind, who's likely to do well with presbyopia correction, who's really interested, what lens choice might be ideal. Unfortunately, patients don't come with signs hanging on them as to what is going to, who's going to be easy or hard to work with. And then furthermore, we're busy. In a week in our given practices, we got a little 10-minute window for each patient during which we as doctors have to be masters of the 10-minute problem-solving session. We have to learn what their problem is, help identify it, examine them, document everything, bill everything, educate the patient. There's just not time to discuss all of the visual desires and premium options that would be appropriate. So we need other ways of profiling patients, and it would be awfully nice if we could know in advance which patients really want premium lenses, and those patients, if they could come to us already pre-educated, and if we could then spend time just where it's going to be well spent with the patient. So one system that's helping us do this that pairs beautifully with Veracity is MD Backline, and this is a patented online system for automating conversations with patients that collects information on their lifestyle and their visual needs. It delivers learning material on different implants before their first visit, and then maintains contact with patients before and after surgery to supplement our discussions. And then after surgery, ensures that those patients are satisfied by asking them and reporting on how they're doing. So, for example, from a patient's perspective, here's the kind of thing they see. They answer some simple questions. It's, they've got a picture of their doctor and a view of something that's written in 5th grade language. They click these radio buttons to answer the questions on their phone or tablet or computer. And then they can take a look at some learning material that gives them very general information about cataract surgery and specifically about what they might expect from different refractive options. Some of us surgeons use femtosecond lasers, some don't. And so we don't, the system, we use the femtosecond laser, so we present that information. For some doctors, that doesn't appear. It also gives us a chance to show our patients reviews from other patients and what they actually said about different lenses. Turns out that premium lenses earn about a 4.5 star out of 5 review, like the most trusted Amazon products. And so patients really are motivated by hearing what other patients have to say, and they can drill down and look into a lot of detail just as they do on Amazon. Probably what we like best about this system is what we call a visual profile report. That is a single page PDF or electronic document that we can look at that outlines what's happening with each patient. And on the top, it kind of shows how serious their visual symptoms are, how bothered are they by cataract, and then gives us information on visual habits and history. Do they use a computer a lot, drive at night, do close detail work? Have they ever done monovision or multifocal contacts? And then it summarizes for us in the bottom sort of what their desires and personality are. So overall, how interested would they be in a better vision, even if it cost more with surgery? And then what's important, distance, intermediate, or near vision. This is helpful to us also because we get a personality self-assessment. How much of a perfectionist are they, like Stephen Dell recommends? And we ask them how much they're bothered, how much they would be bothered if they had some glare, but did not need as much reading glasses in the future. In the bottom right, it gives us a summary of how likely the patient is to choose an upgraded implant. And this is remarkably accurate because it's based upon a number of different responses that the patient gives. And it tells us what's important to the patient and what they're a candidate for in terms of multifocals or monovision. We know that long-term satisfaction with patients is very positive. In other words, we did a study looking 2 to 10 years after cataract surgery at the satisfaction of patients with different presbyopia correcting lenses. And it turns out that well-selected patients end up very, very satisfied. Their 4.5 stars out of 5 is well placed. Patients seem to like interacting with this system that asks them questions in advance, and they don't mind it. They view it as a selection. And here's what we see in practices across the country who use it. Those who, if you do a snapshot of what their adoption of premium lenses is before and after cataract surgery, it more than doubles in the average practice. This is the use of torics and multifocals. And what you see here is the increase in income that comes to the practice once they adopt this automated system. So clearly it's a win, and is a positive for practices. So, a lot of different IOL choices we have, but it's not always easy knowing what is going to work for a patient and who is interested. We know that the majority of patients are interested if they have information presented to them the right way, so that if we can pre-identify and pre-educate patients who are most interested in premium lens options, it's going to yield more productive conversations we have in the office, as well as patients who end up happier, and our practices are made stronger by their enthusiastic referrals of their colleagues. So patient profiling, we think, is an important part of our future.
Well, Dr. Hovnessian, that was just a terrific talk.
Next, we'd like to...
You can tell that was recorded. So, well, thanks, Liz and Sumitra. We have some great case discussions that I think illustrate a lot of the points that you made in your talks. And so why don't we jump into the first one of those? I think, Sumitra, you've got the first one here, right?
Yes, I do. Yeah, this was a great session to kind of go over things. That was a good, good segue, because here we are filling out these different papers, paper copies, but you've got the electronic version. I mean, that's very high tech for the patients who are coming in. There we go, IOL selection. So I'm going to describe the first patient. Ooh, give me one second here. So this is a patient who was highly motivated for spectacle independence. She had decreased vision from cataract left eye more than the right eye, and what we noticed was that the topography and the slit lamp exam was very normal. And so this is a person who comes in. I think her husband had panoptics in both eyes, so she already kind of knew what she wanted coming in. And so topography was great, the slit lamp was great. I guess I wanted to kind of, before we even go into the actual pictures, how do you incorporate some of this ancillary testing, Liz, like the topography and the OCT macula and the biometry? Like, what's your approach when a patient is coming to you for a cataract evaluation at your practice?
That's a great question. I think you have to have a standardized approach, whatever it is, but I do believe that the topography and advanced biometry are absolute essentials. The reason is, I mean, we are very fortunate, IOL Master 700, the Lens Star, the Aladdin, all those very, very good with both K values in the actual quantity and the meridian, as well as with the axial lengths. But you also want to couple that with the quality, and that's where the topography, the placido disc topography particularly, is going to be really helpful to see if the quality of that astigmatism is regular. And then you also want to have device alignment where there's not going to be too much of a difference between the two. I'll tell you, whereas before I did not get an OCT macula on every single patient, but now I think it is so incredibly important that we are checking that, whether or not they're opting to go with an option that would promote spectacle independence. At the end of the day, when we have a surprise outcome, because there was a blunted foveal reflex that we didn't recognize to exist, right? And so that showed to be a grade 1 macular hole, and that patient's vision is not what they were expecting it to be. My goodness, it is a complication that the surgeon caused, even though that was pre-existing. So for us in this day and age, I just believe that getting that OCT macula is of utmost importance. And then of course, just assessing dry eye in some way is going to be the other component to all this, because that has to be coupled with all these diagnostics to help ensure that success, both subjectively and objectively after surgery.
No, I absolutely agree with that, Liz. And one of the interesting things is I used to do it where I did the topography and the slit lamp and the ocular surface check. And then I sent the patient out, and on a different visit, their pre-op visit, I did the OCT macula. But I actually found that here I am spending all this time talking about different lens options. And then if I had known what I knew the next visit, I wouldn't have even gotten into it. So this was an interesting case to me because this is what the picture came out. So our EMR system with the images was not working that well. So they sent down this paper copy, and I was like, my retina colleagues have always said one cut is not enough. And so actually, when you actually go to the next slide, please. When you actually go to the images and you do multiple cuts, take a look. The bottom one looks great. The middle one looks, well, you definitely see that epiretinal membrane. This is that right eye only, multiple cuts. And look at the top one there. I mean, you see that vitreomacular traction, and that's only on that one vertical cut. And you would miss that if you just did a regular printout, which I think a lot of us anterior segment people have been guilty of in the past. But cases like this have really taught me that. So here she is. She wants a PanOptix, but this is her macula. And even though the ellipsoid layer looks okay, there's still a little smudge of maybe something missing in that sort of cyst. And so, first question is, well, now what? Do I refer to retina? I always like to refer these patients to retina. Maybe it's because ease of access. Even though I know a 2025 VMT, they're not really going to be excited about doing surgery, but it kind of CYA for me. How about, John, do you send these patients to retina before, or you just show them the macular OCT and say you may meet your retina surgeon after?
Yeah, it's more, as you know, many of these VMT cases will eventually release and be uneventful, but it's more for the reason that you do than it is for making a decision, because we know pretty well that they're not going to recommend surgery at this stage. So I agree. And I mean, this is a case that could potentially have a presbyopia correcting lens. It depends upon, your comfort with the patient, probably more than anything, right?
Absolutely. And so, this was a decision that we kind of had to make. So I sent her to retina, and I was looking at maybe a low ad multifocal, but I wanted to see what retina thought. And, I think this is where once you send it to retina, they may come back with a stronger statement than you were looking at. So they came back with a stronger statement that was definitely no multifocal in this lens. And I think part of it was that they could just imagine trying to peel an ERM in this high maintenance patient later on through it. Although I've had other retina specialists say that through some of the low ad multifocals, the ERM peel is just not as bad as it used to be. But that being said, she comes back to me. So I sent her to retina, and now she's back with monofocal only. And, this is where mixing and matching can be an option for her. And so we ended up going with a monofocal in that eye. And I was actually going to do a low ad in the left eye. The left eye looked pristine on all the different cuts, but she really talked me into doing a PanOptix. She really wanted it. It was interesting because the rep told me something like, ooh, I'd go with the low ad if you're going to blend with monofocal, the PanOptix is better. But I think we're all just learning more about the PanOptix. And I think, as we get more comfortable with it, and she's thrilled. I mean, her vision's great in the right eye, her vision's excellent in the left eye, no intervention per retina. And I think this is where that gray zone comes in. How comfortable are you? What's your threshold for it? And so I don't know the monofocal on the side, but I absolutely agree with you, John. I think a low ab would be a completely reasonable option as well. And then the second case I'm going to talk about is a patient had a history of hyperopic LASIK. Her right eye was her near eye, and she recently had cataract surgery, and she just wasn't happy with the vision. So it was sent to me because the question was, what to do with the other eye, and should she get an IOL exchange in that first eye? This case was a little bit more complicated because she had the active focus done right before COVID. I think in like January, and the idea for the referring surgeon was, we'll just see how things go. But by the time she actually came and really voiced her complaints, it was 6 months down the line. So I think the referring doctor was like, well, now I really don't want to remove this lens because it's all, scarred in. And so they sent it to me for evaluation. And it's not that her vision's terrible. It's 20/30 J3. It's one of those things where the question is what to do with that left eye, what to do with that right eye. For a patient like this, I kind of start out by saying, what do you do, Liz, with the unhappy multifocal patient who comes in? So this patient, whether it's yours or someone else's, like what are your sort of checklist things that you start with for patients like this?
Well, I think a careful history is going to be so important here, and then listening to them and asking them, were you actually ever happy after your surgery? Like in that first week or 2 weeks after surgery, do you recall just having that wow factor and really enjoying your vision? Because truly, if they never enjoyed their vision from the very get-go, the chances are it's not going to be one of the reasons that you listed. It's not going to be just dry eye or PCO. So, in a scenario like this, then if it was a refractive error plus, you've got PCO, but they were never happy, you're not going to do the YAG because the refractive error correction is not going to make this patient happy. So certainly looking for the regularity of, what their LASIK bed looks like, and also asking them, I would go back even a little further and say, after LASIK, how was your vision? Were you happy then? What was your nighttime vision like? Because all of that quality really plays into a role as to what lens option we should be considering given their various lower and higher order aberrations here.
Very well said. I completely agree, Liz. There are no perfect options for these patients with significant previous hyperopic LASIK ablation profiles because you just have a hyperprolate, very irregular cornea. And so it's certainly a risk to use a multifocal in the first place. Probably this is not a patient I would have used even an active focus in. I don't know what your approach to those is. We did pretty well with active focus, still do. More aberrated eyes tend to do better with that lens, but this is a pretty aberrated eye.
And I think one of the other issues is, they have that unstable epithelium. So they get that dryness that no matter what you do for them, you just can't seem to even with a monofocal lens, I mean, that fluctuation in vision really, really sticks. And so it's one of those eyes where you may never truly make them happy. And so, going with the monofocal. But here's this patient, I mean, her right eye, the question really becomes, what do we do next? So what I did for her is, careful refraction is always important, catching any astigmatism, especially with lenses like the Symphony, catching any, little hyperopia or a little myopia that your tech may not have caught, repeating a topography, making sure there's no retinal pathology. I loved Liz's very important part about were they ever happy with that lens? I mean, that's something that we all have to just really be honest about. Did the patient say, after their surgery, they saw amazing, and then after a couple of weeks, they started noticing a little bit of decrease in their vision? That leads you more to PCO, but I don't think enough people ask that, and that's when you end up having a patient who's unhappy with their lens. They have a big old capsulotomy, and you don't need a large capsulotomy to prove that your multifocal sees well. You just need a really small one in the beginning. You can always enlarge it if needed, but we oftentimes see very large caps. And then some of these refractive errors, you may be able to do something like a contact lens trial. For For this patient, though, to John's point, I mean, it was, like you said, a highly aberrated cornea. I mean, the steepest part is like 48. I mean, when you looked at her slit lamp exam, the dome of that hyperopic LASIK, the tear breakup time was awful. I mean, basically, there's no way she's ever going to have stable vision. And then this is the other eye, even more concerning. She may have had a decentered ablation. And definitely, I mean, this is her distance eye. And so, she was kind of, what should I do? Should I exchange, should we exchange the right eye as an option? Or should we move on to the left eye? And this is where the gray zone comes. So John, for a patient like this, what would you choose? And obviously there's no answer, right?
No, but I think you're stating all the great teaching points here. So first of all, I'm a big fan. If you can go just back a step to the slide, the topography for a second. I'm a big fan of showing patients their own topography before surgery and explaining, if we are going to use a multifocal in this eye, look, this is what I have to deal with. I ask them, so you tell me which power I should count on for planning your lens implant. And they always kind of smile. I go, why are you asking me? I go, of course you can't, but neither can I. There's no single answer, and we don't know exactly how you're going to see. So the point is that now the patient sees the image, the patient owns the irregularity in their cornea. If I don't show them that, I own it, and the bad outcome I own. So we are partners in getting the patient through it. So here in this case, I would pretty strongly consider a lens exchange, because I think it's likely that given this cornea and that implant, that is the direction we're headed. But of course, if you want to advance to your next slide with the options, I think you always want to optimize the surface, and you always want to be sure you've got an accurate topography and make sure the patient buys into. What you don't want to do is something just for the sake of trying something. You want to be very thoughtful in your approach.
And Liz, how about you? Which one would you go with?
So I'd actually ask the patient, and then first objectively look at the visual acuity. It's 20/25 and blurry. I mean, the idea is we're probably going to have to exchange it, but if the best corrected on the left eye is like 20/70, then obviously, kind of discussing, should we get you more balance before we come back and exchange, or see if you're able to tolerate the overall vision if your left eye is clear for the distance, because sometimes people don't want to lose that little extra that they have, even though she does have some corneal pseudo-accommodation because of the spherical aberration that's present. But if she is pretty, and every patient's going to be different, if they're pretty hung up on this first eye, then fix that first eye, exchange it, go with something very spherically neutral would be my go-to, like a zero sphericity Invista or an Eye Pure by BVI. Or if you really see a lot of negative spherical aberration on your imaging, then you could go for a positive spherical aberration lens. That's an option that you can go with, but it kind of depends on the patient.
Good. Well, we want to be sure we get all our cases in. So any sort of last stuff on this case, Sumitra, that we can do?
Yeah, we actually ended up, like you said, Liz, went with whatever decision she wanted. So we actually went ahead with the left eye. She really wanted that distance vision. She was only 20/40, as I said. And right now we're just kind of stable. I mean, she's able to do some of the things. She lives out on the beach on Galveston. She checks her phone, checks her tablet at the beach. She still needs a refraction. And we're pausing on the IOL exchange because, as you mentioned, sometimes they're surprised what they can and can't do, and checking her phone was such an important thing. She doesn't want to lose that, and so we've kind of paused right now.
That's a great choice. And it's difficult many times, isn't it, to get patients to go along with that, because they want the first eye, quote, perfect before they proceed with the second eye. But often giving them binocular summation takes care of a lot of problems, doesn't it?
Absolutely.
Awesome. Great cases. Thank you, Sumitra. Liz, you've got some interesting stuff to present here, a couple of good cases. So go ahead. Why don't we start with your first?
We've got about 7 minutes, so I'm not going to rush through it, but I will try to make sure to keep this as concise as possible. 63-year-old female, and similar to Sumitra's patient, had LASIK in the past. She had myopic LASIK. Number one question I always ask, like I mentioned, how was your vision after your LASIK? The patient was very satisfied with the vision for years. And then number two, what was your night vision like? Until recently, the vision at night was great, but it's become worse. As you can see, This is more difficult because their best corrected vision is still pretty darn good, and their BAT is really the main reason why they're coming into your clinic for evaluation. And whereas before, these were the patients that were, some of the toughest patients to consider surgery for, because they're coming in due to their nighttime positive dysphotopsias, which you're trying to help, and they've had LASIK, and they want full freedom. So the first thing I'm going to look at, obviously, is that placido disc topography. And my attention immediately is going to go to the regularity of that bed. Now, as you can see, as compared to what we just saw, where that very central 2 millimeter, 3 millimeter zone was decentered in the ablation bed, this shows a very nice ablation bed. So, I mean, even without looking at the corneal high-order aberrations, I can already tell you that their spherical aberration is going to be lower than 0.3, and certainly it is when you look at what's going on in the cornea. So this alone tells me, hey, at least one of the things are checked off, which is that another very reassuring thing is with their LASIK, their average corneal power, the beds are very similar. So after the first eye, if there is any surprise outcome, at least I have some similarity in what the corneal power is based on topography, and I can scoot up or down to help me to really hit my outcome on that distance eye. So, I'll quickly ask you guys, do you start in these kind of patients? One, would you consider, an array of lens between monofocal, monovision versus multifocal? And then which eye do you start with? John, what would you say here?
Yeah, sorry, I was just making sure I'm unmuted. I think it's very reasonable to start with the non-dominant eye in these cases, and in many cases, particularly if we're going to end up with a surprise result, we'd prefer to end up on the myopic side, because if it's a non-dominant eye and we end up with a little bit of mini monovision, that's often well accepted. Even if it is a multifocal. And of course, if we're going to be doing a LASIK or PRK touch-up, we prefer to approach those from the myopic side. So yeah, I think that's reasonable. If there's a significant difference in the visual potential between the two eyes, I tend to go with the eye that has better visual potential, so they get the better reward from their first surgery.
Great. And Sumitra, any extra pearls there that you would provide? Do you start specifically more often with one eye versus the other?
I mean, when it's an eye that I'm for, different multifocals where I'm pretty sure that they're going to be happy with it, and they're, it's not one of those rare eyes that are really long or really short where the refractive target is an issue. I sometimes do like to start with a dominant eye, but this is a perfect example where for most of these cases where you're not, this is a post-refractive. So we already are a little concerned about the refractive target's going to be, we don't want to end up hyperopic. That's the rule. I think it's excellent to start with a non-dominant eye. And you already know you're taking a little bit of a gray zone with it, but you have a very well-counseled patient.
Yes. So that's exactly what I did. Was I started with the non-dominant eye. I did aim for, I was trying to aim for a little bit of myopia. So I went with this lens to fix astigmatism using my Barrett-Truquet, all found and housed within the actual Veracity software. Post-operatively, the patient was extremely happy with that first eye. As you can see here, they did end up just slightly hyper. So with my second eye, I adjusted for it, but it does show you that you can get all of this information kind of uploaded, my favorite formula being the Barrett-Truquet, and then ultimately both eyes did quite well. And then you can decide how you want to manage your astigmatism in a patient like this. Since we're running out of time, I'm going to show you just one quick pearl on case number 2. If you have a patient who you see beautiful topographies like this, nice rings, okay, and the capture looks good, your average K values look pretty good, but then there's non-congruous information amongst your various devices. So for example, on this one, the left eye, pretty consistent, really inconsistent on the right eye here. But there was good placido disc imaging. Sumitra, I mean, what comes to mind when you see something like this?
Well, I really, if you're that far off with the axis, where are you going to put this lens? That's one of the first choices. And so I love the way that you've written this out too, because it really showcases the astigmatism magnitude and the axis, is how we encourage everyone to do that. But I mean, if you've got these type of outliers, now one thing is, some topographers, some biometers are a little more sensitive to ocular surface issues. So we have to keep that in mind as well. And so certainly if you can optimize the surface, that's good. But here, I'm not quite sure for that right eye where we're going to end up as far as the axis go. The left eye, though, it's a little bit more consistent.
Absolutely. And what about you, John? Any further thoughts on that imaging?
Well, dry eye is the obvious thing that comes to mind. Your spherical power is really similar between the various devices, but your cylindrical power varies by more than a diopter in some cases. So that's kind of speaks to dry eye.
Absolutely. And the thing is here, it's not that you had spotty imaging on your placido disc, right? What it shows is you can have mild early MGD, but that evaporative dry eye, they can blink enough for a capture with a good tear film because they don't have epitheliopathy. But what shows you is you will have inter-device irregularity. So the inter-device average Ks, the magnitude, the meridian, that's where it differs. So you should think of evaporative dry eye immediately when you see that kind of difference between the images. And so I just kind of wanted to stop there, but that was something kind of that evolved for me over time to recognize that. As a cause of the inconsistencies amongst devices.
Yeah, boy, those are great cases from both of you. Just outstanding, illustrative cases for the kinds of challenges that we all face from time to time. We're getting to the end here, and we'll go just a minute or two over. I want to thank our two faculty, but have just a couple quick questions from our audience. One is, when do you use and not use the TKs, assuming you have an IOL Master 700 or a biometer that gives you that option, versus traditional Ks? What's your criteria for each of you? You want to start, Liz?
I don't use the IOL Master 700. Unfortunately, I've been trying to get one. I use the Lenser, but from my understanding, the TK can add obviously that extra little bit, particularly when you're looking at your post-LASIK patients and kind of assessing astigmatism management in the post-LASIK patient, as that one study did demonstrate that if you compare the different IOL formulas, the True K does perform very well, but having the TK with your optimized HIGUS can perform just as well and maybe even better.
Yeah. Sumitra, anything to add to that?
Yeah, because the Barrett Universal just is the more preferred formula for all different eyes. We do every case, we run, the various lenses with the Ks and then the TKs as well with the IOL 700 with the Barrett. And then we'll just add for the long eyes, we'll add a second formula. Some of the optimization of the various formulas like SRK, Holiday One, they will give you a little bit of a myopic errors for any of those that like to have two different lens choices and like to pick the one in the middle. That's kind of nice because it almost always adds up to kind of giving you, two different options. So that's how we usually run it. And once again, I think that's where something like Veracity is excellent, because if you do that on paper, you're going to have 20 different sheets of paper printing out. And so, I think that's where, being able to just adjust it on the fly is really excellent.
Yeah, I completely agree. And for me too, a little bit like Liz suggested, I like those TKs, particularly for post-refractive cases. But the nice thing is that, as you said it, with Veracity, you have a chance to toggle it on and off and see how much difference it really makes to your lens choice anyway. Last question, real quickly. If you got let's say a pilot or somebody who's very, very sensitive to glare and halos at night, but wants the best vision they can get, what is your IOL of choice? This is an audience question. What do you like to go with? Are you monofocal toric? Is there any multifocal you might suggest? Where are you now, and where do you think you're headed with that in the future?
Right now, I like the zero asphericity of like a lens like the Invista. I think it gives them really good vision. There are some reports, some presentations that were made at last ASCRS about a little bit of extended depth of focus with those lenses. I never promise the patient that, though. I always just think of that as a nice little bonus, but I have been, really surprised about certain patients, especially those with the rule astigmatism, with a little bit with the rule that they're able to come out of it, J3 up close.
Yeah, Liz, do you see the Vivity implant having a role for those, or what do you do?
I cannot wait to see the monofocal EDOF lenses come out, because the dysphotopsias will certainly decrease. It really depends on the patient's personality of how are they okay with the potential of an IOL exchange. If they're okay with the idea that I might have to exchange the IOL because of whatever reason, quality of vision, nighttime dysphotopsias, if they're okay with that and they're looking for that uncorrected range of vision, honestly, I will absolutely put it in a truck driver or a pilot or a surgeon or an attorney. It's just really laying out the rules and the lay of the land. And if they're okay with it, then we proceed. If not, and they're risk averse, that's when we're considering more monofocals. I love the idea of a zero sphericity monofocal. Can't wait for that. Vivity or iHance, you know, so.
Yeah. Yeah, we have decent choices now, and we've got even better ones that are coming. So, well, I want to wrap it up to be respectful of everyone's evening, but Sumitra Khandelwal, thank you very much. Liz Yu, terrific presentations. We had a question about how can these webinars be seen after the fact and viewed later. They'll be available on iTube, and so that's just itube.net, I believe. You can look up iTube and get the exact address, but you can look them up there and you'll see them in their entirety, any of the webinars in this series. And so once again, thanks to a great faculty for a good presentation. Join us again next week for our next session in the surgical offerings from Zeiss. Thanks to our sponsors at Zeiss and to all of you for joining us this evening. I'm John Hovnessian, and have a great evening.
Thanks, John.